but we're going to go ahead since we are at the top of the hour, and I'd like to welcome everyone to the Global PrEP Learning Network. And today we have a very exciting series of presentations talking about experiences from the DREAMS program and scaling up oral PrEP for adolescent girls and young women. And as you all know, this is quite an important topic, as we have seen a substantial investment in the DREAMS program for the coming COP cycle and increased PrEP targets for these young women. And so we're very pleased today to be able to hear from a number of programs that have been delivering oral PrEP to DREAMS participants and learn from their experiences and best practices. Can you go to the next slide, please? Thank you. So so this is an example of the topics that we're going to be talking about today. We'll be hearing, well, actually, let me just go to the speakers. We'll be hearing from Annalise Lim from USAID. She's a senior youth and HIV advisor in the Office of HIV/AIDS, and she provides technical guidance on youth and HIV issues across the HIV continuum with the DREAMS initiative. And she began her work in this field many years ago, working with community-based AIDS in Dallas, Texas, and transitioned to global health with the Peace Corps. Our next speaker will be Ndalk Darise from Project Hope in Namibia. Ndalk is a medical doctor with a specialty in internal medicine and has been working in the field of HIV/AIDS for over 20 years. And he is currently the Senior Technical Director for the Namibia DREAMS project led by Project Hope, Namibia. Next slide, please. Mwanza Njelasani is from JSI Discover Health Program in Zambia. She is a Senior Advisor for Prevention and Behavioral Interventions, and her current portfolio of work includes leading the organization in layering PrEP onto the DREAMS program. She has over 15 years experience and has worked with various organizations in sub-Saharan Africa and was recognized as one of 25 emerging leaders in the field of global health and HIV/AIDS by UNAIDS, which is a very exciting honor and well-deserved. We also have Kumbiri Chatora from PSI in Zimbabwe. She is the Director of Social Marketing and is involved in the development of social behavior change communication campaigns to create demand for biomedical prevention products. In addition to these speakers, we have a number of panelists who are available to answer questions and participate in the discussion. From the CDC, we have Pragna Patel, who is the co-chair of the PEPFAR PrEP Community of Practice and the point of contact for adolescent girls and young women in PrEP. From the Project Hope team, in addition to Ndalk, we have Bernadette Harasis and Samson Ndlovu. We also have from the Namibia mission, Dennis Mali. From the JSI Discover Health team, in addition to Mwanza, we have Mutinta Nyumbu. And we also have some other experts just from the Choice project that is hosting this webinar series. So myself, Christine Toriuson from FHI 360, and Jason Reed from JPIGA. We are the co-directors of Choice. We also have a number of support staff who are helping keep this webinar running smoothly from FHI 360, including Casey Bishop, Aubrey Weber, Katie Schwartz, and Martha Larson. I'm just looking through our panelist list to see if I captured everyone. We're very glad to have all of our panelists here and our attendees. Right now we have over 150 attendees from around the world. I don't know all the countries they're from, but I see a large contingent from Africa, which is great, since that is a regional focus for these webinars. We're going to launch into our presentations shortly, but I just want to remind everyone that you can while the attendee lines are all muted, you can communicate via the chat, and we welcome your communication via the chat. However, we ask that you select the all panelists and attendees button in the chat function. You'll see under the to line, I think unfortunately the default is all panelists, so you actually have to click the little arrow and select all panelists and attendees so that everyone can see your questions and comments. And we know that we have many experts in our audience as well. So if there's a question asked that you feel you can help inform, please feel free to answer that question as well with your own experience being shared. Next slide. Okay, so without further ado, I'm going to turn this over to my colleague from USAID, Annalise Lim, to give us an overview of the DREAMS program and how to keep adolescent girls and young women healthy. Over to you, Annalise.
Thank you very much. So, as we know, adolescent girls and young women, or AGYW, experience an increased risk for HIV infection. So today I will discuss current prevention programming, of which PrEP is a key intervention, and considerations for scaling PrEP and supportive services for our AGYW. Next slide, please. So we will begin by reviewing the PEPFAR DREAMS partnership. Announced by Ambassador Birx on World AIDS Day in 2014, it is an ambitious initiative to reduce new infections among AGYW in high-burden geographic areas. It is a robust public-private partnership and is currently implemented by USAID, CDC, Peace Corps, and DoD. Beginning as a 2-year partnership, it is now PEPFAR's standard HIV prevention approach for adolescent girls and young women 10 to 24. DREAMS is a comprehensive package of layered evidence-based interventions targeted to AGYW who are the most vulnerable to HIV. Next slide, please. Originally in 10 countries and now implemented in 15 countries, DREAMS received a significant budget increase from last year at $189 million to this current fiscal year's budget of $399 million. We are very grateful and encouraged by this budget increase. In addition to these 15 countries, South Sudan will also begin implementing specific components of DREAMS in this fiscal year. Next slide, please. So when I reference the comprehensive DREAMS core package, this includes the interventions that are highlighted here, and they fall under 4 key areas. You'll see empowering girls and young women, strengthening families, mobilizing communities for change, and reducing the risk of sex partners. So when we look at this core package, I think it's very important for everyone to note that these interventions target multiple populations, right? Because the responsibility to prevent HIV infection does not rest solely on an AGYW. Similarly, as you're looking across these different interventions, they're not solely focused on health, but cut across multiple sectors. And anyone who is working with adolescents and youth know that that is very important. Next slide, please. So to look further at the core package, I'm sharing an example of Botswana DREAMS layering table. Every DREAMS country creates a table that includes their primary, secondary, and contextual services based on the core package that I presented in the previous slide, but also according to the developmental needs across the 3 age bands for DREAMS. To note is that all AGYW must receive all services that are listed in the primary package, where services in the secondary package are based on need. And then finally at the bottom, you'll see contextual interventions that are not necessarily delivered directly to the adolescent girl or young women, but to others such as community members or parents. So what does this look like in practice? Next slide, please. Thank you. So here's an example from Botswana, and this particular DREAMS pathway is for the age band of 15 to 19-year-olds. The primary package on the left, of course, are services that must all be received. And of course, it may not follow this linear fashion, right? And some services, such as condom promotion and distribution, might happen more than once. The amount of time to complete the primary package can vary by age band and also by the country implementation plan. If you look on the second column, you'll see our secondary services that are laid out. And as a reminder, the time to deliver the secondary service also varies greatly. A secondary service such as education might cover multiple years for an adolescent girl or young woman. You'll see that PrEP delivery is listed under secondary services as it is need-based. But it's important to note that PrEP cuts across not only the secondary, but primary and contextual interventions. So for example, under the primary package of services, we have HIV education, which we might be discussing PrEP and informing AGYW about this option, as well as in the contextual level of interventions where PrEP awareness and sensitization could be very beneficial and critical for parents, caregivers, and the communities to support AGYW's choice to use PrEP. Next slide, please. Thank you. So here's an example from PCI, Botswana, Dreams as well. And this is a more detailed version, visualizing the process of vulnerability screening, enrollment, assignment to a mentor and group of AGYW, and delivery of the in-school intervention for HIV and violence prevention and social assets building. So when we're looking at this, it's really important to remember that social assets building is necessary to empower AGYW. Skills such as communication, planning, goal setting, these all help an AGYW make an informed choice on PrEP use and continuation, as well as help them create a supportive social network. So I've very quickly taken you through the multiple layered services in the DREAMS program. And we now want to look a bit more at PrEP specifically and plans to scale this intervention. Next slide, please. So here you can see that since 2018, there's been an upward trajectory of PrEP uptake by AGYW 15 to 24. The graph on the left shows all AGYW 15 to 24 in 24 PEPFAR countries. So this is not specific to AGYW in DREAMS or DREAMS countries, yet you still see an upward trajectory. On the right, we are focused exclusively on the geographic areas where DREAMS is implemented. It is not, however, specific to only the AGYW in DREAMS, but to all AGYW 15 to 24 who were living in a DREAMS implementation area. Of course, we know the last reporting period was after COVID lockdowns commenced, and I really want to say how impressive it has been to see country teams and partners adapt quickly with innovations and still being able to reach AGYW. Of course, scaling PrEP services continues to be a priority, so we do want to look at some targets. Next slide, please. Thank you. So here we've disaggregated targets by country as well as by DREAMS implementation areas. As you can see, targets for AGYW 15 to 24 years old in DREAMS geographic areas have increased. And in countries where DREAMS is implemented, they have tripled from last fiscal year to this fiscal year. So while we will be talking about DREAMS specifically today and that program implementation, it's important to note that scaling PrEP is for all AGYW, not only those in the DREAMS program. And of course, this includes subgroups such as pregnant and breastfeeding women and key populations for those 18 and over. And next slide, please. So knowing that we need to be reaching AGYW outside of DREAMS, we do know that PrEP services for AGYW, even outside of DREAMS, should follow the DREAMS approach, but we really want to talk realistically about what can be done at the scale that we're talking. So here you'll see some illustrative examples of what we might consider. The examples that you see here are based not only on the DREAMS package, but on lessons that we continue to learn from our partners in our field teams. And it also represents USAID's approach to youth programmings, which is positive youth development. We know that enabling environment and positive adult-youth relationships are essential. And you can see that we've captured that in examples here with our youth-friendly services, parents, community members, and our AGYW peer network. We also know that technical knowledge is not enough, but it must be accompanied by soft skills. And then of course, as our young adults say, nothing for them without them. So there you see AGYW voice and engagement, because it is critical, absolutely critical if we are going to succeed, that we have AGYW involved in the design and delivery of these services. Next slide, please. So in closing, I'm really pleased that we have presentations from 3 of our partners who are implementing PrEP as part of our DREAMS programs. I'm sure they're going to provide invaluable insights to how we can effectively scale PrEP and empower our adolescent girls and young women. Thank you very much.
Thank you so much, Annalise, for that overview. And we did have a comment to the panelist chat about how Nigeria is not included in the DREAMS intervention groups. But your last slide, I think, highlighted how the DREAMS approach, and we hope some of the learnings that come out of the presentations today are relevant across countries, whether they are part of DREAMS or not, in terms of how to expand oral PrEP access for adolescent girls and young women. I don't know if Annalise, you or Pragna want to comment further on that in terms of DREAMS countries.
Hi, I don't know if anyone from Cameroon is on the line, but Cameroon and I have had quite a few conversations about being a DREAMS country as well. And just to say again, that I did try to highlight, right? We know that PrEP is scaling in DREAMS, that we are happy to work and support any country in their implementation for prevention for adolescent girls and young women, and that includes sharing resources and best practices. And I think just quickly too, I saw a question about my comment about 18 and up, and that was specifically referring to how we define our key population, okay? So just to clarify what I said on that for adolescent girls and young women. Thank you.
Thanks, Annalise. Pragna, did you have anything to add to that?
Yeah, I just wanted to say, we recognize that there is a significant epidemic among AGYW in some of our countries that were not necessarily designated as DREAMS countries, and we're committed to supporting those countries in addressing those epidemics. And we agree that PrEP is a vital intervention, and we're happy to support them and work with them in rolling out PrEP in their respective countries as well.
Great, thank you, Pragna. I think we have time to also address this other question that we have that says, thank you for the nice overview. To clarify, please, is the PrEP target equals education and counseling about PrEP, or offers of PrEP, or actual uptake of PrEP? And does that include adherence? Annalise, do you want to respond to that?
So the one that I was showing, which is PrEP New, is specific to uptake. And as far as the education, we do not have an indicator specific to that in DREAMS. We do encourage countries, and this year even more so, to make sure that PrEP education is part of their primary package for those age bands for adolescent girls and young women, and even looking at how we can incorporate that education not only for the adolescent girls and young women, but also members of the community and parents.
Wonderful, thank you.
There are other PrEP indicators that are not highlighted here, so I certainly welcome Pragna or others from the team to speak to those if they would like.
Yeah, this is Pragna. I'll just add quickly that we recognize that the two MUR indicators don't quite give us a full picture of how well a PrEP program is performing. And things like adherence that you bring up in your question are really important to track. And often the PrEP registers that countries use do have data elements that get at that granularity. And so the PrEP COOP is working on enhanced monitoring and evaluation indicators for PrEP that we hope will help the countries at least have that type of data at their fingertips, even if it's not reported to us here at headquarters.
Thanks for that, Pragna. And we actually do intend to have a session that is focused on measuring PrEP uptake and continuation that will probably take place in February or March of 2021. So stay tuned. All right, let's move on. Thank you to our Annalise and also to Pragna for both the presentation and the answers to the various questions. We're going to move on now to hear from the Namibia Project Hope Dreams Project. Over to you, Ndalk.
Okay, thank you, Kristen. I'll briefly share the PrEP service delivery approach in Namibia. Next slide. The PEPFAR, the DREAMS Namibia project is PEPFAR funded through USAID, and it's a 5-year project. And we are on the 3rd year of implementation. And the goal of the project is to avert new HIV infection among adolescent girls and young women. Adolescent girls and young women in the age group of 10 to 24 are our primary target population, while parents or caregivers and male sexual partners of the adolescent girls and young women are our secondary target population. The DREAMS project is being implemented in 3 regions and 5 priority subnational units, as shown on the right side. Those districts or SNUs are selected based on HIV disease burden, particularly HIV incidence among adolescent girls and young women, teenage pregnancy, gender-based violence rates, as well as feasibility of implementation of the project. And the project is implemented by Project of Namibia in partnership with the Star for Life, Trials International, Lifeline Childline, Namibia University of Science and Technology, and Project of PS. Trials is our clinical partner. Next slide. I think already Annalise highlighted the DREAMS layering table. This table is specific to Namibia. And as you can see, PrEP is a secondary intervention, and our target population for PrEP is 15 to 19 years, as well as 20 to 24 years adolescent girls, young women. Next slide. This is our service delivery approach. The DREAMS Namibia project is using a flexible service delivery approach. We have a facility-based as well as a facility-linked community outreach services. For the facility-based PrEP service delivery, we have at least 1 designated room for adolescent-friendly health service in 27 DREAM-supported facilities across the 5 districts. And either we have renovated some of the rooms or we introduced prefabs in areas where we have a limited space. For the majority of the part, young nurses are providing the services, and they are trained on adolescent-friendly health services. We provide in those youth-friendly rooms integrated health services, including PrEP. There is a strong linkage between facility and community in those sites. And in terms of increasing adolescent girls and young women participation, recently we introduced suggestion boxes, and we are also working with FHI 360 to train DREAMS ambassadors. As we speak, they are being in training. The TOT training finished 2 weeks back in collaboration with FHI, and now they are being trained. In terms of the community platform, we have safe spaces. Currently, by end of June, we had more than 327 safe spaces. These safe spaces are places where 10 to 30 adolescent girls of the same age group meet every week. They attend education on HIV/GBV prevention, as well as social asset buildings. And in that platform, we bring clinical services, including PrEP. These are sessions led by mentors. And safe spaces are happening in schools as well as in the community, basically. In some cases also, we drop PrEPs at a convenient place where the girls prefer, which might include at times even going to the household, particularly during the time of COVID. Next slide. This is just a graph to show you how we scaled up the community-based PrEP implementation. Initially, our implementation was entirely in the facility, but as time goes on, we significantly scaled up community PrEP. And in October, December 2019, 48% of the newly initiated clients were in the community. As the COVID epidemic started, when the March 17, when the emergency state of emergency was declared, the community contribution started to decline a little bit, the proportion, but in terms of absolute numbers, still we are doing fine in terms of community PrEP service delivery. Next slide. We actively screen all sexually active adolescent girls and young women, 15 to 24, for PrEP at all DREAMS entry points. We provide PrEP education as part of our safe space intervention, as well as part of the health facility talks. use a list generated from the MNE system to really decrease missed opportunities. They use that list and call proactively potentially eligible girls using phone calls. And also during the time of COVID-19, our AGYW mentors also use phone call to create demand. We have also tried our best to integrate PrEP as part of positive parenting skills, which is a Family Matter program. And we have also male engagement sessions where we also bring on board discussion about PrEP with potential sexual partners to the girls. We have seen some healthcare providers as well as teachers were discouraging girls to take PrEP. So we conducted workshops really to decrease those barriers. The work in progress, as I already mentioned, we are going to engage Dreams Ambassador to be as peer advocates and champions. We are working closely with FSSD. We are intending also to bring a PrEP discussion as part of the existing government-led community platform like child care protection forums. We are also intending to use local radios as well as short video clips which can be shared through various social media
and Doug,
networks.
Sorry
Yes?
to interrupt. There's a request for you to speak more slowly.
Okay, okay.
Thank you.
Next slide. We are using the PrEP eligibility screening tool from the Ministry of Health, and we are also using the National ART guideline to guide our service delivery. And we have also adapted a DREAMS-specific PrEP flow chart. These are some of the tools we are using to deliver our PrEP services. Next slide. This is just to show you the PrEP cascade from October 2019 to June 2020. We had 6,823 sexually active girls in the age group of 15 to 24. All of them were screened for PrEP eligibility. Of those, 64%, 4,388, 388 were at substantial risk for HIV. Of those, 7 were positive, the rest were negative. Of those who were at high risk for HIV and HIV negative, 68% of them were initiated on PrEP, newly initiated on PrEP. But the rest were not initiated on PrEP for various reasons. One of the major reasons is they refused to be on PrEP. One of the reasons they cited was they don't want to take daily PrEP pills. They prefer to have injections, and they will come back when we have injections. And for the remaining, the 1,221, we had various reasons. One of the reasons is a shortage of human resource. As I said, we do screening at all entry points, but we have limited nurses who are really overstressed. So that might have led to not necessarily offering the PrEP services, but we do follow-up phone calls to really reach out to these girls. And for some reasons, the PrEP could have been offered, but the reason for not being initiated might not be documented. Those are the main reasons for not eligible but not initiated. Next slide. This is just to show you the trend in terms of PrEP new. That's newly adolescent girls and young women 15 to 24 who are initiated on PrEP. Close to over the past 2 years, we initiated 4,035 girls on PrEP. This is up to the end of June 2020. As you can see on the slide, there was a significant increase as we moved from October, December 2019 to January to March 2020. The main reasons are: one, we expanded our geographic coverage. Second, we are intensifying screening for PrEP eligibility at all entry points. Third, we were doing follow-up phone call by our nurses to really decrease missed opportunities. And particularly during the COVID time, also our mentors started to really to use a phone call. And the fact that we have somehow a flexible service delivery model has also helped us a lot. Next slide. This is just to show you that the effort of our adolescent girls, young women mentors who did virtual assessment and service delivery during following the declaration of the state of emergency. We had 22,655 girls in our cohort, DREAMS cohort. of which only 60% had phones. And of the 60%, of the 13,586 who had phones, 11,073 were reached through phone calls, which is 82% of the ones who had phone. And then on the far right boxes, it shows this virtual service delivery gave us other option to even increase demand for PrEP. This is just AGYW led. It doesn't include the nurse-led phone calls. So through that effort, this is mainly in April, we initiated 60 on PrEP, 82 were refilled, 33 were restarted on PrEP. Just to give you a highlight on another option to really increase demand for PrEP. Next slide. If we see the lessons learned and major challenges, I think one of the issues we are struggling is measuring success in PrEP initiation and continuation. We have been, there is a big challenge, particularly in terms of PrEP retention. But is that really a success, or does it show a failure, really? We tried to look into the girls who discontinued PrEP, their reasons for discontinuation. We took a sample of 374 girls, of which 39% they discontinued because they were no longer at substantial risk for HIV, and 12% of them were self-transferred out. So this shows you the majority, either they don't need the PrEP or they have changed their site of PrEP service outlet point. So there is always a dilemma when you have a low PrEP retention rate. Is it really a failure or is it still a success? So it really needs further discussion and further studies to really analyze what is the impact of really our PrEP. But in terms of scaling up, we are doing really a very good job. And the other challenge now is with COVID-19. It's really a big challenge, but we need to find innovative approach, including virtual approach to really increase demand. Taking a daily pill has been also a challenge, but on the pipeline, there are vaginal ring as well as injectables could come very soon. So that may address this challenge, but it has been really a big challenge. Packaging of the PrEP medicine has also been a challenge because girls, they fear stigma from their parents, peers, as well as their sexual partners. So they don't like really to take the way the PrEP it was currently packaged. So at the moment, we are trying to give them a pill bag so that at least they can hide the PrEP medicine in those bags. But the packaging is being discussed at the National PrEP Technical Working Group, but that's something we need really to consider. The other obvious reason is the stigma for being at risk for HIV is also a barrier for PrEP uptake and particularly also for continuation. Yes, I said we have IEC materials, but is it really engaging, informative, and appealing to the girls? That's also another area we need to really investigate as we scale up PrEP significantly. Last but not least is optimizing frequency of PrEP refill visits. Yes, to decongest facilities, particularly in the time of COVID, we need to space visits, but is that really what is the optimum spacing, particularly for girls? Because if we have a less frequent visits, retention could be a big challenge. But if we have also a very frequent visits, it could be also again a challenge, particularly in areas like Namibia, where we have a big geography and widely sparsely populated population. So we need to really strike a balance. I think those are some of the lessons learned and the major challenges. Thank you.
Thank you so much, Andal. That was great. And I'm going to actually pause for questions because we have a number that have come through. So I saw that Samson did reply to this, but maybe you'd like to comment further. Jen Mason asked whether PrEP services were integrated with a package that also offered family planning, and could adolescent girls and young women access both services, including contraceptives, from a single site or provider? Samson did respond, but maybe he said that the same provider offers PrEP services integrated with all SRH services, including family planning.
Yes, that's correct. We provide integrated health services.
That's great. Do you have any challenges with that?
Yes, there is always a challenge, particularly when you integrate services, the workload to the nurses will significantly increase. We are also providing not only SRH and PrEP, they are also providing all other private health cares as well. For any complaint, the girls 10 to 24 who come to a facility, they need directly go to the user-friendly clinics. So that really increases the workload really to the nurses. And at times it might also distract somehow their attention from providing the best possible counseling for PrEP and other services. That's one of the challenges I saw.
Do you see that it decreases stigma?
It definitely. We have seen this particularly in one of the districts in Comas. For a long time, PrEP was given in the ART clinic, actually, and it was not integrated into the other service delivery sites, and girls were not willing really to take PrEP. So we have worked now, and we are integrating in all other service delivery outlets. So I think we are seeing improvement.
Thank you. The next question is whether any demand creation was done through existing demand creation efforts such as STI or FP. So were you integrating your demand creation within the existing demand creation platforms?
Yes, we do that. Particularly when I said the safe space platform, we deliver all kinds of education into that safe space, including SRH family planning as well as PrEP. And as part of also the health talk early in the morning in the facility, besides other topics, we also integrate PrEP as part of that. And if you see also some of our IEC materials, it's not just only PrEP specific, it covers all other topics as well.
Thank you. Can you shed more light on how the male engagements were structured? What was the structure? What messages were disseminated? And what job aids, do you have any job aids to share from these engagements?
Okay, thank you. That's a nice question. When we started the DREAMS project, one of the first things we did was characterization of sexual partners. Following that characterization of sexual partners, because most of the girls.
And Doc, I just lost you.
Oh, can you hear me now?
Yes, go ahead.
Okay, so when we started the DREAMS project, the first thing we did was a characterization of the sexual partners of the girls. Through that process, we have an idea of who can be the potential sexual partners for the girls. Once we know those potential sexual partners, we recruited, trained, and deployed what we call male champions. So these male champions are recruiting either through one-on-one interaction, through their peers. They are bringing the men to this male engagement session. It's a 3-day session. And in that session, we are delivering HIV prevention, GBV prevention, and the SRH topics. We are using a curriculum which is developed by the government. That's how we do. And we are bringing also biomedical prevention services to those male engagement sessions.
Thank you, Andok. Can you share some circumstance that would necessitate facility follow-up after safe space initiation? Why can't they be followed up in the safe space where initiation occurred? Our experience in Kenya is that girls like the safe space and would not like to go for follow-up in a different place unless they were initiated at the facility.
Yes, that's a very good question. For example, in situations where, for us, most of the safe spaces are in school, for example. And the majority of our girls are recruited from the school. So during holidays, during exam times, running the safe space sessions is a bit challenging. So in those circumstances, we arrange either to drop for them at a convenient place in the community, or we invite or arrange for them to come back to the facility. Some of the girls also may change their location, and some of the girls also may be done with their safe space activities. They will complete the curriculum in the safe space, and they don't need to come back to the safe space for safe space activity. So for those kind of girls, we need to continue the PrEP service delivery in the facility if they are comfortable. If not, we'll use outreach to reach out to them in areas where they are comfortable.
Thank you. I'm just going to ask this one more related question, and then I think we'll move on to our next speaker and ask you to answer more questions in the chat, Endog. So it's related to the previous one in that, so PrEP, asking for clarification that PrEP is provided at the safe space, who provides PrEP at the safe space, and how is the experience to provide PrEP at a safe space? And I would add my related question to that, which is, how do you do the quarterly HIV testing in the safe space as well?
So normally the providers who are providing PrEP are our nurses. We have DREAMS-specific nurses, but they are hired through the Ministry of Health. Like our Ministry of Health is a sub to the DREAMS project, so they are hiring them directly. So there are DREAMS-specific nurses. So yes, we do start PrEP in the safe spaces. When we go out to the safe spaces, you see the majority of the safe spaces are in school, and we have rooms dedicated like for either running the safe space session as well as conducting our clinical services there. And we do also have, in some instances, we might use tents or gazebos to really provide our clinical services in a confidential manner as much as possible. So basically, the nurses are going to the safe spaces on a monthly basis for regular service delivery in the safe spaces. So they can provide the rapid testing there. Normally, they draw a laboratory for creatinine determination or for hepatitis B surface antigens. They draw the sample and take it back to the hospital or to the clinic. But after rapid HIV test, they will start PrEP. And then if there is any contraindication, once they get the other lab results, they may be forced to discontinue or to act accordingly. So we haven't seen any challenge. Testing is done in the safe space. We have either classrooms or tents or gazebos, which can give us like a privacy to conduct those kind of activities.
Thank you so much, Endok. You will see when you take a look at the chat that there are literally dozens of questions. I'm not surprised. We have over 200 people on this call, but it's a very rich discussion. I would really appreciate you and your team responding to some of those questions in the chat so that we can keep going. If we have time, we'll come back to them later, but I also want to assure all participants that after the session, we put together what we call a resource sheet, where we take the questions and try to answer them in writing and provide that back out to you within a week or two after this webinar. So we will get to your questions one way or the other. So with no further ado, I would like to move over to our next speaker from USA Discover Health in Zambia. Over to you, Mwanza.
Great, and thank you for the opportunity to share experience of layering PrEP onto the DREAMS program. Next slide, please. Discover Health was amongst the first implementers to support PrEP scale-up in Zambia, and in order to prepare for rollout in 2018, the project undertook extensive training and sensitization of providers, community health workers, and DREAMS partners. Thereafter, we began rollout of PrEP tailored to adolescent girls and young women at substantial risk of HIV by layering the service onto the existing DREAMS platform. In FY20, we provided the service in 28 DREAMS centers in 6 districts, and in FY21, we're expanding into 3 more DREAMS districts in line with the DREAMS expansion plan. Next slide, please. 3 months into our implementation in 2018, we carried out a rapid program review in collaboration with our DREAMS partners, both at HQ and field level. The rapid assessment was conducted to understand the experience and perspectives of clients and stakeholders in layering of PrEP in the DREAMS centers. The ultimate aim was to improve service delivery to respective clients. We carried up rapid telephone interviews with adolescent girls and young women that had started PrEP via the DREAMS program. We conducted visits to households or telephone calls to parents or guardians of PrEP clients, following the permission of the PrEP clients themselves, as well as interviews with Ministry of Health, DREAMS, and Discover Health staff. The survey revealed a number of challenges, and I will highlight a few areas. PrEP was only just starting to be rolled out nationally, and therefore we experienced broader system issues such as the lack of HIV test kits and urine sticks, for example. Additionally, there were challenges with certain provider attitudes and capacity issues, with providers citing concerns about providing PrEP to adolescent girls and young women, when what these clients required were empathetic providers, especially in an environment where PrEP was provided in an information vacuum, as there was no large-scale awareness campaigns about PrEP at that time. Next slide. Consequently, can you, not sure if you're able to see the next slide. Perfect, thank you. Consequently, we undertook a number of measures to address this. I will focus on a few key points. Firstly, we retrained and mentored staff, increasing PrEP knowledge levels and improved interpersonal communication competencies. In line with the above, we initially recruited DREAMS graduates as peer mentors or mobilizers who were already HIV prevention champions. And afterwards, we complemented this with slightly older but still young trained counselors. This has been the pillar of our client support strategy, from demand generation all the way through to adherence support. Additionally, to address lack of awareness about PrEP at community level, we provided targeted support to adolescent girls and young women facing parent-guardian related challenges, whilst at national level, we supported the government to launch a national HIV prevention campaign informed by a human-centered design study that we conducted. A key lesson learned for us was that before we engage with the girl, it's important that we engage everyone around her that has an impact on her PrEP journey, starting from DREAMS and our own clinical staff, to Ministry of Health staff, for example, working on commodities, to area counselors and parents. Next slide. Given time constraints, I won't go into much detail into all the strategies that we used, though to simply note that we have been requested by USAID Zambia to provide this technical assistance to other implementing partners this fiscal year, and therefore we'll be able to avail this more detailed information later. However, from our experience of implementation, we have tailored our service delivery pathway to ensure that, as I mentioned before we even go and speak to an adolescent girl or young woman about PrEP, we have ensured that we have, as far as possible, undertaking a number of measures. This includes engaging parents via existing DREAM center structures and via coordination meetings to ensure that we have the minimum service standards in place, as well as broader community engagement as well within the target districts. Central to all our interventions is the notion that a client's persistence on PrEP whilst at risk cannot be left to an endpoint, talking about adherence support strategies more traditionally, but should be embedded throughout. For example, the clarity with which a peer mobilizer speaks to a potential client about PrEP and helps them understand their experience and feel empowered to do something about it will impact on whether or not this client will persist on PrEP. This was really key when we did the HCD findings. This was one of the main things that came out strongly. However, it's also important to note that this potential client lives in a community, and there are a lot of external factors that may also impact on their persistence on PrEP, such as the lack of commodities, stigma associated with PrEP uptake, and so on. Therefore, a really realistic approach grounding PrEP within combination prevention is important and should be addressed as far as possible. Next slide, please. In part, as a result of these measures, we have seen a steady increase in the number of adolescent girls and young women accessing our services overall, with adolescent girls and young women accounting for 25% of PrEP clients in our FY20 achievement of over 15,000 clients on PrEP. This is significant, as when we started the DREAMS rollout of PrEP, as you see in FY18 there, majority of the clients overall were coming through serodiscordant couples. But this year, so the 25% of our overall clients come from AGYW and 29% come from serodiscordant couples, just showing you how this trajectory has been. And this is despite COVID-19. In total, for this FY, we had 3,318 adolescent girls and young women, a third of whom were 15 to 19, and 2/3 were 20 to 24 that were initiated on PrEP from the DREAMS centers. This is 85% of all the AGYW initiated by Discover Health in FY20. Again, this is significant, as was mentioned before, as this target group is in line with the adolescent girls and young women most likely to become HIV positive in Zambia. Additionally, we have helped the DREAMS program by bringing more of these girls at risk of HIV into the DREAMS platform. They are therefore able to benefit from the DREAMS program itself beyond the simple, just the provision of PrEP. I should add that our agreement with PACT, the DREAMS implementer in Zambia, was as follows, that adolescent girls and young women that are not part of the DREAMS program can access PrEP at the DREAMS Center as long as they're 15 to 24, though they are offered the option of joining the DREAMS program. So it's a little bit different from the previous presentation. Therefore, not all the girls may be active on the DREAMS program. However, we certainly encourage them to be in collaboration with the DREAMS partners. Next slide, please. So this slide talks about continuation rates. And as you can see, it shows that adolescent girls and young women accessing PrEP at DREAMS centers are more likely to stay longer on PrEP than adolescent girls and young men not accessing PrEP from DREAMS centers, with the exception of adolescent girls and young women in serodiscordant relationships and adolescent girls and young women that are pregnant and breastfeeding mothers. Next slide, please. Finally, there are a few lessons learned and recommendations would make as other partners consider layering PrEP onto the DREAMS program. In terms of demand generation and client management, in addition to distinct peer-led demand generation strategies, as we have been doing as Discover Health, we really would suggest that clients consider aligning, please go back to the next slide, or the previous slide. Consider aligning PrEP demand generation and awareness events with DREAMS recruitment exercises, DREAMS parent engagement meetings, etc. We had started layering PrEP onto existing centers in many instances. Therefore, this was not initially possible. But this subsequent alignment has been making a significant difference. Again, context matters, but in our context, the combination of working with slightly older trained counselors and DREAMS graduates has led to a steady increase in the uptake of services. Finally, there is a need for continuous investment in social and behavior change programming across the service delivery continuum in order to sustain services, such as integrating SBC products into DREAMS centers, such as the videos we produced, the brochures and animations that were based on the human-centered design study that we conducted, and ensuring that service providers have the requisite interpersonal communication skills, and that there is intensive engagement with communities around the adolescent girls and young women. Next slide, please. In terms of clinical service delivery, a very practical example of alignment is ensuring that PrEP is provided on family planning service provision days. So in our case, we don't have that one provider providing both PrEP and family planning services. So we had to look at ways to ensure that this synergy existed. And this has ensured that we're already targeting openly sexually active girls. While again, on the issue of alignment for partners that may be layering PrEP onto an existing program, we know that a person that understands their own risk is more likely to persist on PrEP. And therefore, by working with DREAMS staff who have already undertaken extensive counseling with girls, we can help identify girls that may be at risk. Though interestingly, as noted before, we have also found that our strategies have also helped the DREAMS partners capture more of the 20 to 24 age group that may not consider the DREAMS program before. In conclusion, would like to believe that layering PrEP onto the DREAMS program has been of benefit both to our DREAMS partners as well as ourselves programmatically through cross-learning, and ultimately, and most importantly, this has been beneficial to the girls in our target communities. Thank you.
Thank you so much, Mwanza, for that excellent presentation. We do have a few questions, and really you have addressed some of them and your team has, but a lot of the questions relate to the layering of PrEP with other DREAMS interventions. So I have some questions here about how do you manage your data and layering of services for DREAMS, and also having different partners offer different components of the DREAMS intervention to the same girl. What are the challenges with that model? So the first was around data.
And I think certainly that does pose, absolutely. So we developed a PrEP management information system in 2018. And so that enables us to track track a PrEP client across the service delivery continuum at individual level. Though the DREAMS program has its own DHIS, and so it's been a matter of trying to marry the two, and certainly that does bring its own challenges. What we've tried to do is to have regular monthly meetings between the DREAMS Center managers and our staff to go through the data and just to make sure that we're not missing out. And again, that idea of alignment where we try and as much as possible when, for example, the recruitment exercises are happening with the DREAMS program, that our staff or our peer mobilizers go with them and just try and build that synergy that way.
Thank you. And one follow-on question to that, to the layering is when you say, it says, please help me understand when you say layering onto DREAMS program, yet PrEP is an integral intervention in the DREAMS program. Maybe it's just, maybe for those less familiar with the DREAMS. Yeah, I think it's an explanation of how the DREAMS program works.
Yeah. Exactly. So you have sub-partners that work within the DREAMS program. And so we were, or partners that work and provide different types of interventions within that DREAMS program. So it may not be the same partner that is providing the same service to all the girls. You might have different types of partners. But what was a bit different from our end is that we were not initially part of this consortia. And so we were requested to, as a clinical partner, to come and provide this specific service. And so that is a bit of the difference in terms of our engagement with the DREAMS program.
Thank you very much, Manza. Thank you for that wonderful presentation. I don't see any additional questions right here for JSI, so I think we're going to move on to our next presenter, which is Kumbiri Chatora from PSI in Zambia. And Kumbiri, you were a bit late in joining, so I haven't checked your mic. Can you say hello so we can hear you?
Hello, can you hear me?
Yes, great. Okay, we can pass right over to you. Thank you.
Thank you very much. So I'll be talking about how we have worked with the DREAMS ambassadors in mobilizing adolescent girls 15 to 19 for PrEP. Next slide. So PSI Zimbabwe was offering PrEP in 6 districts in COP18, and we have since had 4 new districts added in Matabeleland South Province, which is one of the provinces with the highest HIV prevalence in the country. And we offer the DREAMS secondary package of care to adolescent girls, and this includes HIV testing as an entry point to biomedical interventions such as PrEP. And key to note is that in addition to the standard sexual reproductive health products and services, we are also offering information on menstrual health and also distribute menstrual hygiene products, particularly the menstrual cup. And for a long time, since COP18, the program has been facing challenges in the uptake of PrEP for adolescent girls. Their contribution as adolescent girls to total numbers of adolescent girls and young women initiated on PrEP was as low as 27%. However, this almost doubled to 51% after we trained former DREAMS club facilitators to work as peer mobilizers. And these DREAMS ambassadors had a special mandate to mobilize adolescent girls for PrEP and contraceptives. And one thing that we've really learned is that working with these DREAMS ambassadors as peer mobilizers has demonstrated that if you put young people in the forefront, they can actually achieve very strong PrEP outputs, especially if they are meaningfully involved with adequate training, and if they are put in the forefront of conducting IPC sessions with adolescent girls. Next slide. So we offer PrEP through static sites at our New Start Center, testing centers, and through outreach in the community. We have differentiated service delivery models. We offer services where it is convenient for the clients. It could be anywhere in the community, at a community hall, at a shopping center, in the bars or brothels, depending on their need. And then we have the Dreams ambassadors there to help us generate demand among the adolescent girls, to also guide us where there's demand. Next slide. So the Dreams ambassador approach is that they use menstrual health, as I mentioned before, as an entry point to discussing PrEP and contraceptives. And from our human-centered design work, we also noted that girls fear being judged and stigmatized as sexually active. And as such, they're very hesitant to seek services. So talking about menstrual health provides a camouflage to screen them for risk, and then weave in messages on PrEP and contraceptives. And we are also distributing the menstrual cup because we've seen that affordability is an issue, as adolescent girls depend on parents for such things. And our strategy is very peer-driven. The Dreams ambassadors are in the forefront, suggesting ways to reach the girls. During outreach, they conduct IPC discussions with the girls, while the clinicians are just in the background to answer technical questions. And it is the Dreams ambassadors who are leading the clinicians to places where the girls hang out. And I must say that in the past, our clinicians would just go to shops early in the morning and wait for adolescent girls that never came. But now with the Dreams ambassadors, they are showing them places like boreholes, places like the back of markets, where the adolescent girls hang out. And also these Dreams ambassadors know certain times of the days when adolescent girls are coming out, such as late in the afternoon when they go out and buy vegetables. So they time their outreach during that period. And when the adolescent girls arrive at our clinic, the Dreams ambassadors again take over. They help them with site navigation by hand-holding them throughout the process. And through the site navigation, the Dreams ambassadors is just they're trying as much as possible to make the client experience a pleasant one for the girls. They're trying to remove all obstacles that the girls may face at the clinic. And most importantly, they make sure that the girls do not have to wait. And this is very, very important because adolescent girls are timid and they really find the clinic experience very frightening on their own. Next slide. And the Dreams ambassadors also work as part of a respected, they're a respected member of our site level team, cluster team. And this team is made up of a clinician who is a team leader and also community mobilization cadres. And we also noted that girls, they just want their services here and now. So if you mobilize them, they want the services there. So you find that sometimes we have to make sure that we mobilize and we give out services at the same time. And the Dreams ambassadors are also leveraging on other programs, the condoms promotion activities. They tag along when the male circumcision teams go to schools and anything happening in the community, including the Stop the Bus events. And we have also created a youth advisory board, which is made up of 6 Dreams ambassadors. This board meets regularly to discuss opportunities for PrEP in the field and how best they can strengthen youth friendliness at our clinics. This is an ongoing activity, and we're still learning how best we can strengthen it. Next slide. So before they commenced work, the Dreams ambassadors were trained on what constitutes youth friendliness, because we realized that to attract adolescent girls for PrEP, we really needed to be youth friendly in our approach. So after this training, the ambassadors were deployed to access services as mystery clients at our clinics. And these findings from the mystery client exercise really highlighted several gaps in our youth friendliness. But on a positive note, the girls found that the security personnel were the most friendly at the site. But the rest of our providers were found to be very judgmental. They failed to appreciate that the girls needed services on time, just like everyone else, so they kept them waiting. They also failed to appreciate the girls' need for privacy. So these insights were disseminated back to our providers, and they really helped us to re-examine ourselves and to reconfigure ourselves to be more youth-friendly in our provision of PrEP. Next slide. So this graph shows program data illustrating the impact of this Dreams ambassadors intervention on adolescent girls' uptake of PrEP. As you can see, our PrEP uptake for adolescent girls was quite low, only 27% contribution in COP18, and this is now doubled by almost half. And we see a corresponding increase in uptake of PrEP from May, when the DREAMS ambassadors started coming on board, through August. And the dip in September and October was due to some internal staff reorganization in preparation for COP19. But despite this, the contribution of adolescent girls' uptake has remained higher than previously, even with these disruptions in September and October. And we see a dip in COP20 in 2020 due to COVID-19. But again, there's a gradual increase with the easing of movement restrictions. Next slide. This graph looks at continuation rates for adolescent girls and young women. Adolescent girls' continuation rates are very comparable to other population types. Their continuation is very high in the beginning and drops sharply after about 3 months. We are still trying to understand issues of continuation, why girls are starting and stopping, and how is this linked to their risk at that time. So as a program, we have expanded our routine data collection among the PrEP cohort so that we further examine continuation on PrEP in different risk contexts. Next slide. So we have learned that DREAMS ambassadors enhance uptake of PrEP among adolescent girls because they come across as non-judgmental, and they are seen as providing safe spaces to discuss and open up. And with training, they can be mentors for providers on youth friendliness. Again, girls want differentiated service delivery. They want the services in their own spaces and at their own convenient time. And site navigation, again, makes it less frightening for our adolescent girls. Next slide. Integrating menstrual health is an entry point, also helps them to open up and for us to start talking about PrEP and contraception. Mentorship and continuous youth-friendly training with testimonials from the girls themselves keeps the youth friendliness agenda alive at the clinic. And finally, we've noted that adolescent girls are a very sensitive group which needs to be meaningfully involved in service delivery and also mobilization. And we believe we've gone some way to achieve this meaningful involvement through the DREAMS ambassadors. Next slide. So in COP20, we plan to introduce a branded campaign called V to further increase demand for PrEP. And through V, we will actually be training our healthcare providers, again on youth friendliness. Also, we'll be providing girls with a trendy starter pack, which is a makeup bag and a pill case. As packaging has been mentioned and has been seen to be a huge barrier because adolescent girls see the pack as too big and stigmatizing. And we also still have gaps in continuation. And through this V campaign, our DREAMS ambassadors will guide the clients and help them with continuation through weekly reminder messages. Next slide. Thank you very much for listening.
Thank you so much, Kumbi. That was a wonderful presentation. It was really interesting for me to see that integrating menstrual health into the services, that is a novel one for me, and I'm very impressed. We do have some questions here. There is a request for some more information around the characteristics of the 15 to 19-year-old girls. For example, are they in school?
Mm-hmm. If I can answer, most of the clients of the DREAMS girls that we are seeing for our program are actually out of school. And we are mainly targeting the out of school young girls. Most of them are not yet married, they are single. Some of them are single mothers, having had early marriages. Thank you.
Thank you. And I think your slide on the continuation rates was very interesting. There were some questions on continuation for the previous speakers as well. Do you have any sense of how many of the young women who stop PrEP then later restart PrEP? And what are some of the factors that contribute to stopping and restarting?
I will give this opportunity to my colleague, Stefano, who's also here to answer. But first, I just wanted to say, yes, we have had situations where the girls, they start and they go on just for about 3 or 4 months, and then they drop, they wait for some time, and then they come back. We have some girls that are living in the border towns where their husbands, they just get married, and the husbands then go off to South Africa, which is a nearby border country with us. So when they come back, you find that the girls go back on PrEP. So it depends on the context. And this is what we are trying to find in our data analysis at the moment.
Yeah, Kumbi, I wouldn't have anything else to say, but what you have said covers everything. And to just say that when we do a more longitudinal analysis of our data using the electronic medical record system that we have put in place, we expect to be able to quantify the number that drop off and how long they stay off PrEP and when they come back. Now we know that they drop off and come back, but we are not able to quantify.
Thank you. It's definitely a very important topic, which, as I mentioned earlier, we are going to address in a February or March Learning Network session. I don't know, Jason Reed from JPIGO, I'm not to put you on the spot, but I'm wondering if you want to make any comment on this issue of continuation and cycling on and off.
Just to say that we have noted that that's a frequent occurrence, that well over half of people who appear to discontinue PrEP by current indicators actually restart at a later date, that the duration between the initial stop and restart is largely variable, but is also predictable if you're monitoring longitudinal cohorts. So it is possible to identify people who are likely to have delays before restarting. And we think a reasonable goal for programs is to try to minimize the delays between discontinuation and restarts, while also supporting PrEP users with better counseling around how to effectively stop and restart. And all of those measures are possible. And like you said, we hope to address them in a webinar just like this one in early 2021.
Thank you, Jason. There are a number of questions about the V campaign, Kumbi, and Annalise has responded with a link to the information about that on PrEP Watch, but I'm wondering if you want to comment. There's a question about what does V stand for in the V campaign.
Thank you for that question. So the V campaign was developed using human-centered design in South Africa, and we are adapting it here in Zimbabwe, also using human-centered design. So V was just a brand identity that we young girls identified with. Yeah, it was part of the brand identity that they identified with, that they come up with. So V actually signifies peace. It's a young gesture that many young people like to use. So this is one of the reasons why it was used. And also V is very, very strong. And in this campaign, we are trying to give power to the young girl to be confident, to be who she wants to be, to aspire to be someone else who knows where she's going through PrEP. Thank you.
Thank you, Kumbi. Another question is, how are you interfacing PrEP and school reintegration among those who dropped out of school? Do you have any success stories to share on reintegration?
So like I mentioned, we are mainly focusing on the secondary PrEP we are mainly offering the secondary interventions for dreams. So we are mainly focusing more on service delivery, and when it comes to reintegration, we then refer to other dreams partners who are working in that aspect. I hope that answered your question.
Thank you, Kumbi. So we are done with our questions for Kumbi. We did have a lot of questions from the original, from the initial presentation that Endal gave, but I note that a lot of those have been answered in the chat. But I did want to give an opportunity to our panelists who have been responding in the chat to perhaps highlight some of the key issues that they have seen emerge in the chat and respond in real time with a bit more detail to which ones they thought were the most important. Before I do that, though, I see one more question coming in from Claudina. It asks, how has been the community mentor training package? I think, Kumbi, that's for you.
That's for me. Oh, okay. So the training package that we have is mainly for our providers. We trained the Dreams ambassadors on how to interpret youth friendliness at the clinics, and then we asked them to do a mystery client. And then the Dreams ambassadors, the Youth Advisory Board, continue to do some mentor training with our providers. Is like I said, this is a new intervention and we're still finding ways to strengthen it, but we have a list of questions that they go through and that they use to train also the provider. So we have some sort of curriculum that they use to train the providers on that. Thank you.
Thank you. And there's also a question on how are the ambassadors facilitated?
So can you come again on that? How are the ambassadors
facilitated? I'm wondering if this relates to how are the ambassadors trained or supported?
Okay. Yes, so we have an onboarding curriculum. When they come on board, we have a training curriculum where we go through all the interventions or the service interventions that they will be talking about. We have a discussion guide that we have developed for them that they use to guide the discussions. The discussion guide is mainly focusing on menstrual health as an entry point and then delves into their reproductive health anatomy, and then goes into PrEP and modern contraception. And then after that, we have refreshers every quarter for the ambassadors. So we are in constant touch with them, and we also try to have training for them in terms of being like confidence, self-esteem, since they are the ambassadors for young people in the communities. Thank you.
Thank you, Kumbi. And related to that, I did put in the chat a link to a publicly available ambassador training package that was developed by Options. That was a previous project that hosted these webinars before Choice did. We just switch our projects, but keep the work going. And the Options HIV prevention ambassador training is specifically focused on adolescent girls and young women, but under Choice. It is now being updated for all populations, and we hope that that new module will be uploaded in a matter of a few weeks to a month. And in addition to that, our colleagues at WITS RHI in South Africa developed a interactive virtual training session on the oral PrEP sessions that can be done online by peer ambassadors, and that one is also very close to being launched and hopefully will be available in a matter of actually that might take a month or so before we can upload that because we have to make a few more programming changes. And then, as Endalk mentioned, we have been working with the Project Hope team in Namibia, and we hope to work with other DREAMS programs as well on a interactive virtual training of trainers for for DREAMS ambassadors, but focused on the HIV prevention and PrEP component. And so that is trying to address some of the challenges amidst COVID-19 and more physical distancing. How do we continue to keep momentum going on these trainings, and hoping that offering a virtual or digital option for training of trainers would be helpful. So happy to share more information on any of those if you would like to reach out to me. I see someone is mentioning they don't see that training material for ambassadors. Maybe Katie, you could repost that link, and then we'll also include it in the resource sheet. I'm going to go back to the panelists now for any sort of final reflections or remarks. I know particularly the Project Hope team, you had a lot of questions you answered. Are there any that you'd like to address live? Endog?
No, I think there were a couple of questions on stigma, which is also a challenge we are facing, particularly in schools. Even teachers have been discouraging girls not to take PrEP, and girls who are taking PrEP, some of them are considered them as like promiscuous. So this is a big challenge. And with the introduction of DREAMS ambassadors, we're having an engaging and then user-friendly communication materials. We believe we can destigmatize PrEP in the community, and with that we can address the issue of stigma. Testing, yes, we do as per the guideline. We do testing either in the safe space as well as in the facility. Initially, after 1 month, at 3 months, and then every 3 months we provide HIV testing as per the guideline. I don't know if I missed some other questions. You can remind me, and then I can answer them as well.
I think that's good. We'll just go through each of our speakers and see if they have anything else they'd like to add. Mwanza, anything from you? I noted that you were talking about the importance of parents in the chat.
Exactly. I think that is really critical, and I'll give an example of one of our experiences. When we first started, we really engaged with the young people, the adolescent girls and young people themselves, but we had neglected to really engage with parents. And we had an experience, a really experience where a parent ended up stopping the girl from starting PrEP. Well, when she found that the drugs stopped her from taking PrEP, but then a few months later, the girl then became HIV positive. We went back to that same community afterwards, and that was around the time when we're doing the review. And when we had the coordination meeting, and this parent came through and was saying she wished that people had spoken to her about PrEP and the value of PrEP, because then she would have made a different decision. And as a result, her daughter basically became HIV positive. And so for us, it really spurred us on to say, before, and I think I said this before we even engage with that girl, it's important to really critically look at the people that have an impact on this girl, and have critical conversations around that, but also center PrEP as an option for them as well. So it's not just about the girl, and this also helps with the issues around stigma associated with it, because it's not just targeting one population, but it's a prevention method that a number of people can consider for themselves. And so for us, I think that initial experience really re-emphasize for us the importance of engaging the people around the girl and making sure that as far as possible, we're able to just try and destigmatize PrEP by making it an option, making it people feel that it's not just targeting the girls alone, but also targeting the communities themselves, and for parents, et cetera, et cetera. So I think that was the addition I wanted to make around the parent and engagement of parents and guardians.
Those are excellent points, Mwanza, thank you. Kumbi, do you have any final reflections or comments you'd like to make?
Yes, I just wanted to highlight the issue of being youth friendly. I think it's it's a requisite before we start offering services for PrEP and even contraception, particularly for young girls, adolescent girls who are very timid, who are very stigmatized in the community. We need to set the basis of youth friendliness. But I would want to hasten to add that youth friendliness is a journey. It doesn't happen overnight. You go forward and you go backwards again. So it's important to be always interacting with the providers, always be reminding them of this vulnerable group, of this very hesitant group that is adolescent girls and young women. Thank you.
Thank you, Kumbi. And I think if you have any resources on how to promote youth friendliness that you could share, that we could include in the resource page for this webinar, that would be great. For example, I don't know if you have tools that are around values clarification for providers or other community members, that would be, or other staff, that would be really terrific to share.
Noted. Thank you. We can share.
And then I'll turn it over to, let's see, Pragna, do you have any final reflections?
I think I really enjoyed hearing all of these presentations, and there were some really creative innovations, and it would be great for us to continue this dialogue as some of the countries are just starting PrEP among AGYW programs and could certainly learn from other countries that have a wealth of experience. And so just wanted to thank everyone who presented for sharing your experiences. Really great work, and we look forward to scaling up PrEP within the PEPFAR space this year and the years to come.
Thank you, Pragna. And Annalise, any final reflections from you?
Yes, thank you. So I think we've heard quite a bit in the final reflections about the role of parents and community and of youth-friendly services. And I think I would also like to highlight again the discussion around AGYW's perception of risk and her choice and ability to continue PrEP use. And so I'm also going to share an additional resource in the chat box.
Annalise, you just went on mute.
Oh, sorry, thank you. I'm going to share a resource as well, because under Youth Power Learning, we do know some of these soft skills that are critical for AGYW, especially to have positive outcomes in health. So higher order thinking skills, self-control, communication, positive self-concept, all of these are going to help AGYW be able to make an informed choice as they continue their PrEP use. So thank you very much.
That is terrific. I want you to hold for a poll at the end, guys. I do want to just mention though that there were an impressive number of questions in this, and I really think it shows how much interest there is in this particular population and in these programs, and that we have more to learn from one another. I'm very appreciative of our wonderful, outstanding speakers and colleagues in the panelist room. And yes, you can go ahead and launch the poll. There you go. We will be putting together a resource sheet. You can see the link here on this slide for the Virtual Learning Network webpage on PrEPWatch, where you can find the slides, the recording, and the resource sheet when ready, when it will be posted there. And then we look forward to seeing you on future presentations. This webinar is every, I believe, fourth Thursday of the month. And we will be taking a break in December, but back with you in January. So just thank you all for participating. Please answer the poll if you can, and we look forward to seeing you in the new year. Oh, yeah, in November. Sorry, in November we have one more, and then from there to the new year. Thank you all.